Welcome to Westmead Private Hospital's virtual GP education program. Today we are joined by Dr. Rabia Shahik and Dr. Dave Listanio, obstetrician, gynecology and fertility specialists. Today, Rabia will be discussing gynecological conditions and fertility, and Dave will be covering endometriosis, surgery and fertility. So to kick the night off, I'm going to hand you over to Dr. Dave Listano. He will be presenting on endometriosis surgery and fertility tonight. Dave has a special interest in fertility, PCOS, endometriosis and fibroids, laparoscopic surgery and obstetrics. He has private rooms in Westmead, Cogra and Haymarket, and he operates at Westmead Private and St George Private. So I'll hand you over to Dave and you can fill in any bits that I missed out, Dave. So over to you. Thanks.
Appreciate it. Thank you very much, Sandra. Hi, everybody. Thank you very much for joining us this evening. Wish we could do this in person, but have to settle for Zoom for tonight, hopefully soon. So tonight I'll be talking about endometriosis and in the context of fertility. We'll focus on the clinical management, and also at the end of the presentation we'll touch a bit on just a small case study. If at any point anybody has any question, feel free to stop me. Can just probably put the question in the chat and then I'll answer it as we go. Firstly, no conflict of interest on my part. A bit about me: I was born in Indonesia. I was sent to Singapore by my parents when I was 9. I spent primary school and high school there, and then in year 10 I came to Perth, finished high school in Perth and came to Sydney for uni, and I've been here since. I did my French Cock training predominantly at St George Hospital. We got rotated around regional and rural hospitals around New South Wales. During my training, I completed the Masters of Reproductive Medicine and also a PhD in oocyte biology. I then did a dual fellowship in fertility and advanced laparoscopic surgery. My practice these days comprises mostly of fertility and IVF, where I manage a lot of PCOS, menopause, donor, and fertility preservation patients, along with basic reproductive medicine. I have a special interest in laparoscopic surgery, particular treating endometriosis and fibroids. I also enjoy performing laparoscopic hysterectomies and managing ovarian cysts laparoscopically. I enjoy obstetrics very much, and so that's still a big part of my practice, and also general gynae, and I'm able to consult fluently in Mandarin and Indonesian. So we'll just get straight into the presentation. So just an overview of endometriosis to start with, and then how do we diagnose it, basic investigations, and finally treatment. Particularly, I'll be focusing on certain red flags that should warrant an earlier referral for specialists. So just a brief overview. So the pathogenesis for endometriosis is multifactorial, so to say. The most famous or well-known pathophysiology is what they call the Sampson's theory of retrograde menstruation, whereby instead of during menses, instead of the lining shedding down into the cervix and outer vagina, it sheds upwards around the fallopian tubes into the pelvis, and that's how we think that endometriosis deposits happen in the pelvis. But that theory, as feasible as it sounds, it doesn't actually explain why endometriosis happens in, say, premenstrual girls, postmenopausal women, women who had self-injectomy, or in men sometimes. So other theories, less well known, but I think equally important, includes what we call metaplasia of the peritoneum. So certain cells in the peritoneum, for whatever reason, be it environmental signals or epigenetic signals, would then transform into endometriosis. Another possibility is we think it could be spread through the lymphatic system or hematogenously through blood vessels. And this could sometimes explain why we can have endometriosis, say, in the lungs, in the spines, so extraperitoneal deposits. But all these are fairly academic because there's nothing that we can do really to kind of to prevent this. So then we just, at least not yet. Therefore, the treatment modality involves treating the disease after it happens. Now, endometriosis, the underlying problem with it is it creates inflammation and oxidative stress, and this commonly leads to pain. The hallmark is generally chronic pelvic pain that fluctuates during periods. So typically women would describe pain worsening just before or during their menses. Now, because the endometriosis deposits could technically be anywhere in the pelvis, sometimes it can overlap with certain symptoms like a urinary or bladder symptoms. So when we get endometriosis on the bladder peritoneum, it could create a lot of urinary symptoms. Sometimes when we have bowel endometriosis, could create bowel symptoms such as constipation, bloating, diarrhea. So that could sometimes overlap with like, say, irritable bowel syndrome symptoms of that. Sometimes if we have big endometriosis cysts, also known as endometrioma, that can sometimes grow to be quite big. So this can cause pressure symptoms like a pelvic mass. And what I feel most strongly about is the impact of endometriosis on infertility, which we'll get to in a bit more detail later. So how do we diagnose endometriosis? Clinical symptoms, fairly classical symptoms like we talked about, so cyclical pain. We need to consider differential diagnosis. So PID, we need to exclude. Sometimes they've got underlying IBS, irritable bowel syndrome. Sometimes when they're heavy urinary symptoms, they could in fact have interstitial cystitis, for example. These are kind of red flags that I think would warrant earlier referral. So firstly, persistent pelvic pain that's not responsive to basic analgesia or hormonal therapy. By basic analgesia, I mean just basic NSAIDs like Nurofen, Voltaren, and regular Panadol. Hormonal therapy such as the pill, pretty straightforward, Mirena, and sometimes aromatase inhibitors, so such as letrozole. If, for example, you could palpate tenderness or mass on examination, that should probably warrant further investigation. If on investigation such as ultrasound you see an endometrioma, we'll talk a little bit more about endometriomas later and why it's relevant with infertility, and also finally women who present with endometriosis and infertility. So this typically would be like 12 months trying to conceive without success. But keep in mind that for older women, so women above 35, probably worth referring them earlier, say after 6 months of trying to conceive without success. And this is mainly because of the poor egg quality, not only age-related, but also endometriosis-related. So investigations, pretty basic. So after history and examination, generally we would be interested in what the ultrasound shows. So a pelvic ultrasound, generally we're trying to exclude obvious things, things like fibroid or severe adenomyosis, which sometimes you could see on ultrasound, and also big ovarian cysts such as endometriomas. Generally, if it is only superficial peritoneal deposits, we won't be able to see it on ultrasounds. But that doesn't mean that the woman doesn't have endometriosis. Some ultrasound places could also describe, say, the sliding bowel signs. So that's also a nice sign for whether or not there's severe endometriosis. Some ultrasound places could also describe the pouch of Douglas. For example, if they have severe stage 4 endo with obliterated pouch or involving the rectum, sometimes they could describe that. MRIs are not first line investigations, I'd say. Sometimes I do order MRI. For example, if I suspect severe stage 4 endo with bowel involvement, especially rectal involvement. But generally, we don't routinely ask for MRIs. There are certain biomarkers. Oh, hey, there's a question, Sandra.
There is a question. Do you request pain ultrasound or transvaginal?
Yeah, good question. So we generally, they should, in women who are not Virgo intacta, who have been sexually active, we would prefer a transvaginal ultrasound on top of a transabdominal. The reason for this is it's much more accurate and much clearer picture, particularly to assess the pouch of Douglas. You almost certainly need a transvaginal approach. So most ultrasound places would understand to do a TV ultrasound.
Okay, thanks.
Biomarkers. So there are certain there are talks of certain biomarkers that endometriosis lesions release into the blood, but most of them are still experimental. So we don't rely much on biomarkers. Sometimes people talk about CA125 being raised, but again, CA125 is not a very specific marker. Sometimes inflammatory markers like CRP or ESR could also be raised, but those biomarkers rarely change our management, so we don't really look at them. The gold standard for investigation and treatment is still a diagnostic laparoscopy. Not only that, but we want to get a biopsy so we could confirm that histologically. Oh, yeah. So treatment. Basic treatment like regular Panadol and NSAIDs, so Voltaren and Nurofen are actually quite effective in treating endometriosis-related pains. Hormonal therapy like the basic OCP, Mirena is good. Dianogest, also known as Vicen, can be very good. Failing that, sometimes we could give kind of stronger hormonal suppression like aromatase inhibitors or GnRH agonists. And finally, treating the infertility, that's a bit of a gray area whether or not you do surgery first and then do ART, so assisted reproductive treatment, or you do assisted reproductive treatment, in the form of whatever, ovulation induction, IVF, for example, and then do surgery. I think it needs to be assessed on a case-by-case basis, but certainly if if the main issue that the patient presents with is infertility, then that's probably what we should treat. Or the thing to keep in mind also is the dilemma with treating endometriosis in the context of infertility is that a lot of the treatment for the basic medical treatment for endometriosis actually precludes pregnancy. So for example, the hormonal treatments, can't fall pregnant on that. The NSAIDs, no good for pregnancy. Therefore, in treating endometriosis related infertility, we generally say either surgery or ART. So surgery, gold standard remains laparoscopy. So a general principle for treatment include seeing and treating. So you go in with the camera, have a look, systematic surveillance of the pelvis, and where you see endometriosis, you treat it. By treating, I mean we debulk the disease, kind of like cancer surgery. So remove as many as you can safely and restoring anatomy. So this could improve not only symptom-wise, but also infertility. Now, ablation versus excision. Ideally, we should always excise with a decent margin. So this, firstly, you get the biopsy for histopath assessment, but also you prevent recurrence. But certain endometriosis lesions might be too dangerous to exercise safely, then in such circumstance, then probably ablation could also be reasonable. And one of my special interests is managing endometriomas. Endometriomas are what also known as chocolate cysts, as you may heard before. So these are essentially endometriosis deposits within the ovary. Now, the dilemma with this is endometriomas is associated with reduced ovarian reserve. It's associated with poor egg quality. There's more and more research to suggest that the oxidative stress caused by endometriomas are no good for eggs. Plus, the treatment for endometrioma, so generally cystectomy, where we remove the cyst wall from the ovary, this almost always would cause injury to healthy ovarian tissues, even in the best in the hands of the best surgeons. And the reason for this is when you remove the cyst, they tend to bleed, and when they bleed, we dithermy. We buzz. Now, in buzzing, you inevitably would destroy healthy follicles, and with that, you compromise their ovarian reserve. Now, in women with infertility in whom ovarian reserve might already be compromised, when faced with endometriomas, that's where we could get into trouble. So this is just some photos, laparoscopic photos of someone with endometriosis. So you can see here, this is the ovary, that's the left tube, and that's the uterus. So we're staring straight into the pelvis. And this is the ureter. And this is the rectum, just at 6 o'clock there. Now that area is diseased. So that area, we won't be able to see it. Even in the best ultrasound with the most advanced machine, you won't be able to see that. And the only way we could know that is clinically and laparoscopically. If you look closely in the pouch of Douglas there, the rectal mucosa is also, the serosa is also abnormal. On the right side, again, quite diseased peritoneum. Post-surgery, that's what we do. So excision, so we excise whatever abnormal peritoneum that we see with a decent margin. Speaking of endometrioma, I'm currently running an RCT where we're testing a new surgical technique in management of endometrioma to see whether or not this can improve ovarian reserve. So I got slides on this. So on the left there, on the left ovary is a classic endometrioma, so chocolate cyst. Typically, what we would do is we would cut open the cyst and strip the cyst wall from the ovary, and that's where the bleeding happens, that's where the buzzing, dithermy happens, and that's where the damage happens. But what we're testing is, if you could see here on the top left corner, my forceps is holding a syringe. So I'm injecting a vasopressin solution into the endometrioma. And what it does is it helps to hydrodissect, so using the solution to dissect the cyst wall of the ovary. Not only that, but the vasopressin should help with hemostasis as well, so it vasoconstricts. So we do that, the cyst ruptures, and then standard cystectomy, so we strip the cyst wall of the ovary. The only difference is there's barely any bleeding in this one. So then we just suture the ovary close, and voila, no buzzing, no damage to follicles. So this is a technique that we're currently studying whether or not it helps with maintaining ovarian reserve. We had a couple of months ago, I had a patient, Alice, she was 32, came to see us for mainly infertility, but on further questioning, she also has symptoms of endometriosis. She is nulliparous, never been pregnant. She's been trying to conceive for over 12 months with her husband. She reports regular periods. She reports quite moderate to severe dysmenorrhea and mild dyspareunia, deep dyspareunia in certain positions. The rest of the history were unremarkable. Her husband, Roger, is a healthy 33-year-old who's never fathered a pregnancy. Investigations. So Center for Basic Investigations. The probably the most relevant biomarker as far as fertility is concerned is what we call AMH, the anti-Müllerian hormone. In her case, her AMH was 9. Keep in mind, for a 32-year-old, the 50th centile should be about 20. So hers is relatively lower than average, probably closer to the 10th centile. A high COSI showed she's got bilateral patent tubes with normal endometrial cavity, but she did have a 2-centimeter complex cyst in the left ovary. Now, in the context of her symptoms, this 2-centimeter cyst could be an endometrioma. Semanalysis, so that's SEE, semanalysis was normal. So her options, so in this case, we talked about what we can do from here. One, we could conservative, so keep going, but I wouldn't recommend that, particularly she's already been trying for 12 months with a low AMH and known endometriosis. So we should probably escalate into some form of treatment. With treatment, do we excise the endometrioma? Do we go in laparoscopically and excise any endometriosis and also drain the endometrium? Or do we run an IVF cycle on her before doing the surgery? So she, given that her primary objective is to fall pregnant, we decided, you know what, she said, she would like to go ahead with IVF. So we did do a round of IVF where we got 7 eggs. Not bad, but a little bit low for someone of her age. Out of those 7, we got 2 good quality blastocysts. 1 was transferred and 1 was frozen. A few weeks later, we did a pregnancy test and it was negative. So we had another chat and say, well, where do we want to go from here? So this time she opted to have the diagnostic laparoscopy with a plan to remove the endometrioma. Now, in her case, we actually didn't remove the endometrioma. A few reasons. Firstly, the cyst was quite small. And secondly, her AMH was already low. So what I did was just to drain it and ablate it. So gently just burn off as much endometrioma as we can. Yep, and then we also excise some superficial peritoneal endometriosis. This is mainly to control her symptoms, but it's the endometrioma that is most relevant for her egg quality and fertility. Following that, we recovered for a couple of weeks, and then we planned a natural cycle frozen embryo transfer. She fell pregnant with that. She's currently 13 weeks, and pregnancy is going well. And she's booked with me at Westmead Private. This one's a very, how do you say, a nice story outlining kind of step by step, classically with someone with endometriosis and infertility. So,
it's just
summary,
a question that's come through, Dave. So, what is the best approach for 2-centimeter ovarian cysts?
Yeah, good question, Fahima. So, ovarian cysts depends, right? The age of the patient, the appearance of the cyst, right? Is it a simple looking cyst? Is it a complex looking cyst? Are there any suspicious features? 2 centimeters is by no means big. Sometimes when we think about cysts, we worried about the risk for torsion, for example, or symptoms for patients. So generally with 2 centimeters, the risk for torsion is quite low, number 1. And number 2, patients generally probably won't even feel. Generally 2 centimeter cysts are what we call incidental findings. But say in a postmenopausal woman with a complex appearing 2 centimeter cyst even, we need to investigate further. So generally someone like this, we run a tumor markers. And if that's normal, then we talk to the patient whether or not she would like just surveillance or she would want it removed. A different case though, if someone's young with normal tumor markers and completely asymptomatic, So in that case, we generally would say, let's just repeat the ultrasound in a couple of months' time, because it could well be physiological cysts.
All right, there's another question here. How is ablation different from diathermy for the treatment of endometrioma?
Yeah, very good question. So with ablation, we don't strip the cyst wall, and we don't ablate on the ovary directly. We ablate on the cyst. Whereas with diathermy that we talked about earlier, it's diathermy to the ovary, which is bleeding. So traditional treatment for endometrioma, you drain the cyst, you strip the cyst wall of the ovary, and almost inevitably the ovarian base would bleed. And that's when you diathermy. And that's, I mean, that's in the hands of the best surgeon. You diathermy for hemostasis. We can't let the bleeding continue. So with ablation, you keep the cyst there, but then you ablate as much as we can to prevent recurrence. Yeah, so highly prevalent endometriosis. Probably the last stats, probably 15% of women between 25 to 44 is known to have endometriosis, and that's relevant because 25 to 44 is that's our productive, as productive as we get. And with endometriosis, chronic pelvic pain, infertility, that's no good. It's often underdiagnosed, unfortunately. Laparoscopy is the gold standard. See and treat. So that's a basic principle. We've got different treatment modalities. Depends on what their primary complaints are. So if a patient presents, she's in her early 20s, she's working hard in uni, juggling 2 different jobs, and she's got chronic pain, the treatment will be different than someone, say, in their early to mid 30s whose primary complaint is infertility. And lastly, we'll keep in mind certain red flags for early referral.
Okay, just a couple more questions, Dave. Don't run away too quick. The best investigation for ovarian cyst, and will that cause recurrence of cysts?
Yeah. So with Fahima's question, best investigation for ovarian cyst. So depends on the case, right? So ultrasound is fairly non-invasive, fairly accurate. So almost certainly we need an ultrasound, and just basic tumor markers. So we've got generally an array of 3 or 4 tumor markers. For example, if it's someone young, so we need to consider, say, a germ cell tumor or sex cord stromal tumor. So you ask for AFP, HCG, and LDH, for example, including in addition to CA125 and CA19.9. Whereas if someone postmenopausal, older women, then you're not too worried about germ cell tumor or a sex cord stromal tumor. So you generally just order basic tumor markers, CA125, CA19.9, and CEA. And then from there, we can talk about different options. But generally, if someone's postmenopausal with a cyst, we tend to go in to at least have tissue diagnosis because we don't want to be missing cancer. Komal's question, will that cause recurrence of cysts? I presume, Komal, you're talking about the ablation of the endometriomas. Yeah, so very good questions. We don't know, but intuitively you would think that, yeah, it could cause recurrence of cysts because ideally you want to remove the cyst and then you want to close off that space with suturing to really prevent recurrence. But again, we need to weigh up the risk and benefits. So for example, in Alice, our patient, she's got subfertility, she's got low AMH, she's got endometrioma. I think in her case, predominantly we just want to drain the cyst. We want to minimize recurrence, so by ablating the cyst rather than stripping the cyst, even using the technique that we talked about earlier with vasopressin, can't guarantee that it won't injure ovaries.
Okay. How often do you need to do follow-up ultrasound for the
hemorrhagic cyst? Yeah, good question, Manpreet. So hemorrhagic cysts, we sometimes sun just opened. Hemorrhagic cysts can sometimes be a corpus luteum. So with that, you probably just do or we just do like every 2 to 3 months.
He wants to join in.
Sorry.
Oh, good.
Not everyone can access diagnostic lab. How about arranging a deep DIE ultrasound? Yep. Sarah, a great point. You're right. So a DIE scan is becoming more and more mainstream. But keep in mind the correlation between DIE and laparoscopy is not 100%. So if we looked at just now my earlier slide with the superficial endo, like this kind of endo, we won't be a DIE scan would also not detect that. So doesn't mean that the women don't feel the symptoms. So at the end of the day, the gold standard is diagnostic lab. And I gotta say, like in Australia, it's fairly easily accessible, diagnostic laparoscopy. And in the hands of people who know what they're doing, it's a fairly safe thing. So we offer that. We have quite a low threshold. This is my mobile and my email. Feel free to call me anytime if you want to discuss any of your patients, and email me any questions. Thanks again for having me.
So thanks, Dave. I'd now like to hand you over to Dr. Rabia Shaheek, who will be presenting on gynecological conditions and fertility. Rabia has a special interest in endometriosis, laparoscopic surgery, and male infertility. She has rooms in Westmead and operates at Westmead Private, along with a public appointment at Westmead Hospital and Nepean Hospitals. So I'll now hand you over to Rabia. Perfect.
So again, thank you everybody. And I am going to discuss some common gynae conditions. And as Dave said, that you can ask questions in between or at the end, whatever, however you like it. So I thought that we can discuss some important gynae issues which can have effect on fertility and pregnancy. And I believe in continuity of care, and I look after all my patients and deliver their babies, and I take them till the end, and most of my patients like it very much. So what are the common things which affect us is age is the most important thing. And I cannot emphasize on age that if a patient is trying for 6 to 12 months and they're over 35, please, they should seek some help. And I see for so many years that I've seen that you guys are fantastic and identifying the problems and then referring them at the right time. And you have done all the investigations for them. And some of the GPs actually have done the AMH for us, which makes life so much easier for us to actually advise them what to do. Common problems, what we see in our practice is ovulatory disorders, which is PCOS, and I'm sure you guys see them all the time. We see patients coming in with irregular periods, or the periods are not coming, or they're becoming lighter, and they think that they might have polycystic ovaries because they've heard from their friend, but actually they are perimenopausal for different reasons. And when we do their AMH, why the periods are irregular, we find that the AMH is very low. Endometriosis is very common. It is common than what we think. And I think it is more common for us because we see the cohort of women who are unable to fall pregnant. So when we see them that they're trying for 6 months, 12 months, younger girls, 27, 30, and they're unable to fall pregnant and they have got dysmenorrhea, it's hard for them to have sex, or they're feeling fatigued, then we know that 6 out of 10 of that cohort actually have some type of endometriosis. And as we all know, that endo ranges from mild to severe. And as Dave correctly said, that some of the superficial endo is not diagnosed on ultrasound, and laparoscopy is the gold standard. Pelvic adhesions, which could be from previous surgery, like if somebody has a ruptured appendix and they have pelvic adhesions causing tubal issues, or tubal blockage due to some STI or some other previous surgery, or due to endometriosis, or they have had some infection in the pelvis and they had hydrosalpinges, all these things will affect them falling pregnant. The other newer diagnosis, which we are seeing more and more often as fertility specialists, is the cesarean scar defect, because we see that cesareans are on rise, and most women are now electively asking for Caesars, and I would not disagree with many women. If somebody comes in at 39 and she has taken 5 years to get pregnant, and if she comes in and asks me to have an elective Caesar, I would offer her. But we see that some women, for like failure to progress or fetal distress, and have a Caesar at 7 centimeters or 8 centimeters, and then they would suffer from secondary infertility, they would have a cesarean scar defect, and we're seeing them now quite often. So endometriosis, I'm not going to cover much because Dave has covered it nicely. It affects all stages of fertility. It distorts the anatomy of the pelvis. It has got an effect of chronic inflammation. It affects the transport of the egg and sperm. And it also affects it reduces the ovarian reserve, and it affects the egg quality, and it affects the chances of IVF as well. In tubal issues, a blockage of one or both fallopian tubes do cause infertility, and it is quite common. Tubal factor infertility may result from infection through STIs, as we said, chlamydia, previous surgery, or somebody like tubal ligation. They've got 2 kids and now they've remarried and they're trying for pregnancy. Now, some women discuss tubal reversal, and if it is an easy reversal, we would offer, but we discuss with them about pros and cons of tubal reversal, then chances of ectopic, and then easy accessibility of IVF. And in different sectors, IVF is available in the public, in low-cost units, in a public setting, and it's much more accessible financially as well as compared to doing tubal reversal. So many women would revert to IVF. Hydrosalpinx is commonly seen with endometriosis as well, and it affects our IVF chances as well as causes chronic pelvic pain. Now, most women with tubal issues are actually unaware because they don't have any symptoms. Some of them will have acute pain or chronic pain, or some of them will have no symptoms whatsoever. And it's only diagnosed on hypocrisy or on a diagnostic laparoscopy. How do we diagnose tubal issues? Is by hypocrisy or by HSG. I am personally not a big fan of HSG, because it does not give us much more information about the pelvis as compared to hypocrisy. So I mostly offer my patients to do hypocrisy. Or if they have got pain as well, then of course we would rather do hypocrisy, we would do a laparoscopy to exclude other pelvic causes. PCOS is a very common problem, and we see that all the time in our practice, and I'm sure you're seeing a lot of girls, a lot of women in your practice with PCOS, with irregular menstrual problems, or you will feel that, I'll quickly stop here and have a look in the chat. Had menarche at 10, getting periods irregularly every 3 to 4 months. Now she's 15, no dysmenorrhea. Does she need any investigation now? Look, if she had menarche at 10 and she's getting periods irregularly, we say that if girls have got, so we give them 2 years for the HPO excess to develop. If the HPO excess is developed and she's still having irregular periods, I would at least do a transabdominal scan, and depends on the BMI of the patient or the girl. If we don't see the follicles, at least we can get the volume of the ovaries. And I would also do their insulin at least to see what is their fasting insulin. Because if they do have PCOS, then they might have some insulin resistance. And if they have the BMI is high, then lifestyle modifications is the first line of treatment. But if you think that ultrasound is normal and the ovaries are normal size, they're not more than 10 million volume, and the insulin is fine, then I will give them some more time in terms to develop their HPO excess. I hope I've answered your question. So what happens is that PCOS, we don't know the exact cause. It's multifactorial. We mostly see menstrual dysfunction. And if they're younger girls, as I said, they said, so the best guidelines for PCOS are Gene Health guidelines, very easy to understand. And it feels like a novel you're reading. It does not feel like that you're reading a text or studying or anything. So it's very good. But if they are, and I would agree with Ram that yes, with increasing obesity and with the lifestyle we're seeing more and more of this, that the periods are irregular. Not necessarily all the irregular periods are PCOS though. So before we actually label anybody with PCOS, younger or older women, we must investigate. And AMH is also a very good marker, but we cannot rely on AMH unless the woman is more older than 25. We see metabolic issues with these women. We see androgenic side effects in these women with acne, hirsutism, male pattern, hair loss. We see, and the girls would come in that my iron is low because I'm losing hair, and you would know that they would have PCOS. That's why they're losing hair. And of course, if they're younger girls, 28, 29, 24, and they have got irregular periods, they don't have any estrogen in the system. So if they don't have estrogen in the system because they're running on baseline low estrogen, they're also at the risk of bone loss. So it's important to deal with these women in terms of either on the pill, if they're not desiring fertility, or offer them fertility with ovulation induction or other sort of options. We see them when they are actually struggling to fall pregnant because of anovulation or oligoovulation, or insulin resistance, or obesity, or most of these women would also have hyperplasia or polyps in the uterus.
So Rabia, just a question on PCOS. Is it more common these days with rising obesity?
Yes, we are seeing obesity is a pandemic, and we are seeing that more and more girls are now obese. PCOS and obesity goes side by side, hand in hand, but not all the obese women have PCOS, and not all PCOS women are obese. So there is a 25% cohort of women who are lean PCOS, that they do have PCOS, but they're very lean. And there are a lot of obese women who don't have PCOS. So it's important to actually separate them and see what is going on. And are we diagnosing these PCOS correctly? So this is the diagnosis of PCOS, and it's a gold standard diagnosis that we need to have at least 2 out of these 3, following that they have irregular periods, like they have got less periods, they're not ovulating, they do have clinical or biochemical evidence of hyperandrogenism, like if they have got bloods, their free androgen index is high because their sex hormone binding globulin is low, or they've got higher DHEA, or they have got acne, they have got hirsutism, they have got extra hair on their body, on thighs, on tummy, and they have got darker coarse hair, or they're losing hair, then these are the signs of clinical signs of hyperandrogenism. Or polycystic ovaries. Sometimes they go to a normal ultrasound place, which are bulk billing places, and nothing against them. They are doing so many scans, they cannot sit there and measure those ovaries. So if you're trying to diagnose PCOS on a woman, I would like to do their AMH, I would like to do their bloods, and I would also like to do a good ultrasound to see what is the volume of the ovaries. If only one ovary is more than 10 mils, it is a diagnostic criteria, ultrasound criteria for PCOS. So what do? We tell them to lose weight, and most women after losing weight will start having regular periods. Not all women would start ovulating, but of course it's best for them if they have periods. Then we know that maybe simple treatments will work for them, like just simple tablets like clomiphene citrate or letrozole. Most of us now, fertility specialists, are not giving clomiphene citrate. We are now moved towards letrozole because it has got less risk of doing a multifollicular development, so less risk of twins, and so less side effects, and this goes, yes, higher chances of pregnancy. If the woman is not ovulating despite giving the ovulation induction, we add metformin. Or if they've got higher insulin resistance, then we will add metformin. Or if they have got other problems on top of PCOS, like painful periods, or we don't know if the eggs are, if they have got the very high image and they failed letrozole trial despite metformin, then we will book them for a laparoscopy and ovarian drilling and the dye at the same time. And we'll also do a biopsy of the uterus to see if the lining is extremely thin, if the endometrial breakdown, if there's any hyperplasia, and then we'll take it from there.
Rabia, what's the role of what's the role of testing AMH in PCOS? There seems to be a very high variability in results for the same patient, which can cause anxiety in patients if one reading is low.
Okay, so in PCOS, PCOS means polycystic ovarian syndrome. Now, it is a misnomer. They're not cysts, they're follicles. So if somebody has got PCOS, they should have a higher AMH because this is like AMH is actually relates to the number of the eggs and the reserve of the eggs. So we cannot say if somebody has got, and AMH is not a number. We cannot say that if I've got a 39-year-old woman and her AMH is 14, then it is probably a very good number for her. But it's not telling me that this woman has got PCOS. And again, if I have got a 24-year-old woman or a 27-year-old woman and her AMH is 14, then I'm a bit worried because this is low for her age. So AMH should always be used in a context of age, that if I've got a younger woman, so there is a very good chart which divides the woman into ages and then say that what will be in a normal distribution, in a bell-shaped curve, the 50% of women, they should have AMH of, if there is a woman between 30 to 35 or 30 to 34, their AMH should be 50% should have AMH of 20. So if it's less than that, I would tell them that your AMH is borderline low for your age. But again, the same number for an older woman would be actually better for them. So in PCOS, generally we see higher AMHs, not lower AMHs. And when we see that, so how we say, if an ultrasound says the ovaries are 4 mils, and we can see 8 follicles in one ovary and 5 follicles in the other ovary in a 30-year-old woman, it's actually a low reserve. In a 30-year-old woman, you should see 10 follicles in each ovary. But Sarah, there is a high variability in AMH results. AMH is basically, so you can do it at any time in cycle. This is why AMH is a good marker, because it does not affect, it can be affected with the pill. If somebody's on the pill, then you will see variability. But generally, if the reading is low, like if it's lower than their age, then there has to be a reason for that.
She was very happy with your answer. Thanks, Rabia.
Okay. So then we will move on to uterine anomalies. So what uterine anomalies we see, and it's really funny that in last 1 month, I've seen 3 unicornuate uteruses, which is really sad because one of my patients had a properly normal ultrasound and we started IVF and we did 2 transfers and she did not get pregnant. And I offered her to do a diagnostic lab and she has found to have endometriosis and a unicornuate uterus. So sometimes it is not always possible to diagnose these things on a normal ultrasound. So what do we normally see? Either septate uterus, bicornuate uterus, arcuate, unicornuate, diadelphys, agenesis. These are all congenital abnormalities of the uterus that they are when the female fetus is formed. Uterus comes into 2 portions. So it one comes from one side and the other side, and they join and fuse. And then the septum in between actually resolves and it becomes a nice normal cavity. So if something happens during the congenital time, then we will have either one side uterus and the other side is rudimentary on the other side and they haven't fused, or they have got a heart shape, or the septum hasn't resolved. So they affect in different ways. The bicornuate and diadelphys are probably the most fertility friendly type of congenital anomalies. Unicornuate takes a long time to fall pregnant, and then there are risks with them. that they can either present with menstrual abnormalities, they can have preterm labor, they can have miscarriages, or if the uterus does not stand nicely, then these girls will have short cervix and they will break their waters and have early deliveries. But most girls who do fall pregnant, they do quite all right. So case number 1. So I thought I'll prepare, all 3 of them are my cases, and all of them have actually had successful births. So this one is a 34-year-old G2P0 trying for 2 years after her previous 2 pregnancies required a longer time to conceive as well. One miscarriage was at 6 weeks, and the other pregnancy, she was diagnosed to have an ectopic on the right side, and then she was, because the beta HCG started to go down, they managed her conservatively, but they said you have got a right ectopic. So when she came and told me that she has got this history, but she suffers from dysmenorrhea as well, and she also have got premenstrual spotting, we did her AMH, which was 9.2, and 9.2 for a 34-year-old is borderline low. It should be about 14. So we organized a HyCoSy for her, and they said she has got a normal retroverted uterus and left unilateral patency. They could not see the right side. So I took her for a laparoscopy, and I don't know if you guys can see this clearly.
Yes.
So what I found is that this is her cavity. So when I put the camera in, I could only see one left cornua. I could only see one fallopian tube opening. I could not see the right side. But the cavity looked pretty decent to have a baby. And of course, as soon as I put the camera in, I realized that she's got a unicornuate uterus, and that's why they could not see the right side. On laparoscopy, you can clearly see that it's a right rudimentary horn, which is not connecting to her left side. This is her uterus, which looks a normal size. It does not look small, but it is attached to a left tube and the left ovary, and the right ovary and the right tube is attached to the rudimentary horn, which is not attached to the left uterus. So, and she has got grade 2 endometriosis, which I excised at that time. And then she became pregnant naturally without IVF. And I gave her a prognosis going up to 34 weeks. I put her on progesterone pessaries throughout, and I managed her with cervical length, serial cervical length monitoring. But she surprised me. She went up to 37 and 4, and I did a Caesar for her because the baby was pretty high. She delivered a beautiful little girl. And after that, I told her that maybe they were mistaken of the ectopic. They thought this is on ultrasound, this is an ectopic, but it was actually her rudimentary horn. And now she's trying for a second baby. So diagnosis was that she had got unicornuate uterus with right rudimentary horn, left patent tube, right was not connected. So implications was that, that of course her AMH was lower because of her endometriosis. So it affects the egg number and egg quality. So we offered her IVF, but then she became pregnant naturally. So of course, and then she had a good outcome. Case number 2. This is a 37-year-old G2P0, primary infertility of 7 years. SFA was normal. They was trying. She complained of some pain in her pelvis, but otherwise nil major concerns, trying naturally, no problems. Her AMH was pretty good for her age. We did a HyCoSy, which came back with bilateral tubal patency, but ultrasound showed she's got large ovarian cyst and a 13 centimeter subserosal fibroid. So in fibroids, if we have got fibroids are like location, like real estate. So it depends where they are. If they are completely outside the uterus, it is pretty black and white that if they are not causing any problem to the woman, then we don't like to remove them. If they're subserosal. If they are submucosal, that they are in the cavity, in the lining of the cavity, they have to be removed because pregnancy is difficult. If they are intramural, like they're half in the muscle of the uterus and half outside, then it depends on the size of the fibroid and symptoms of the woman. If they don't have any symptoms, we don't like to touch them. So because she has got a large ovarian cyst, I decided to do a laparoscopy for her. And this is what I found. So she's got a large ovarian cyst, which was a cyst adenoma, and I removed that. She's got grade 2 endometriosis, and you can see the inflamed lining. They're very tiny superficial dots, but you can see the blood supply. And she's got this huge fibroid next to the uterus. If you can see that, it feels like she's got 2 uteruses. And she's got a intramural fibroid as well. But this was pretty small. This was a 3 centimeter fibroid. Now, cavity was perfectly normal. Nothing affected the cavity. This fibroid was outside. So I told her that I don't have any reason to remove this, but we did IVF because she has got time to conception was 7 years. We did IVF. She became pregnant in the first cycle. She did have a little bit of problem during pregnancy because it was quite uncomfortable for her, but she went up to term, had a perfectly nice delivery and no problems at all. And she still has got this fibroid.
So just before you go on, Rabia, just another question.
Yep.
How long should we trial metformin in a patient with subfertility who has PCOS and insulin resistance before referring on to gynae?
If you are only giving them metformin and their periods are regular, they can try for 3 to 4 months, especially if their AMH is normal and their age is young. The other thing is that if you are seeing a patient who is trying for more than 6 months and they are getting quite frustrated, now come back to a normal sort of a couple who is having sex because they are their partners, or a couple who is having sex or timing their sex because they're trying to fall pregnant. They're using ovulation kits. They are trying all the time. They are making sure that they're having sex in their fertile period and they're taking all the multivitamins. I'm sure you're seeing couples like that come into you and say, oh, I was taking Elevate, but I've stopped taking Elevate because nothing is happening. So a woman or a couple who are trying for 3 to 6 months naturally, and they're doing all the right things and they're not falling pregnant, they come to you, they find out they've got insulin resistance or they have to lose a little bit of weight, then they go and do that, but nothing happens and they would continue to have periods. Their stress levels and their anxiety builds up. By the time they end up seeing us to start ovulation induction or do some cycle tracking, of course, we don't want to jump into IVF straight away. We would like to know if they're young and they've got good egg reserve and sperm is normal, and on the history we don't find much, we would try for them to do cycle tracking to help them time their sex. That look, this is, it gives them reassurance that we have seen a follicle, we have seen your lining, go and have sex now. It will give them a lot of confidence and reassurance. So if you see a couple who is actually getting a bit anxious about things, then I would probably give them 2 to 3 months and then send them for ovulation induction trial. Again, there is no guarantee that if they start IVF, the IVF would work straight away. So sometimes they try naturally for a longer period of time, and then IVF also doesn't work for some time. So then it just stresses them out a lot. And stress plays a big part in their success as well. So I see that if I've got couples like this, I'm very sort of close to them. I would just drop a text here and there, or just give them a call and say, hey, I just wanted to check how you are. How's everything going? Is it like becoming like a ritual for you to have sex? Or are you like just like really stressed out? And if they say yes, then on the next appointment, I would say, look, guys, tell me how you want to proceed. Do you want to move on? Are you happy to continue trying, or do you want to move on with either IUI or IVF or whatever? So I sort of put the ball in their court and see how they are, not to stress them out. That's all. So if you see, you are the best judge. If you see that they're really good, they're coping well, they're happy to try longer, then yes, of course.
Just another question here. What is the role of, I've got to pronounce this, clomiphene citrate with high BMI and PCOS? Is it preferred on metformin after lifestyle modifications and exercise?
Okay, so clomiphene citrate is an ovulation induction agent, which basically is an anti-estrogen, and it works to make the FSH, to reduces the estrogen, so FSH is high, so make them ovulate. If they are on the higher side of BMI and they're insulin resistance, then clomiphene plus metformin is the best treatment for them, plus lifestyle. Lifestyle is the first thing to do. If they're doing the lifestyle, they're cutting down their carbs, they're doing a little bit of exercise, they are reducing their weight a little bit, everything works better. And if they do get pregnant, the pregnancy is also better. So you're preventing them from gestational diabetes as well. If they've tried clomiphene citrate so we add metformin if they failed the ovulation induction with clomiphene. But if they're already on metformin and you add clomiphene citrate, some women do ovulate on metformin as well, because insulin works with your LH and they become best friends and they tell the ovaries not to ovulate. So if somebody has a normal BMI but high insulin, you put them on metformin, they will ovulate and they can fall pregnant themselves. But if they're not, then you can add clomiphene citrate or you can add letrozole. Letrozole is slightly better because the pregnancy rates are better with letrozole.
And is it worthwhile to check day 21 estrogen levels in PCOS patient as well who are planning to start family in a patient who is using medical treatment and without treatment?
So if you are giving somebody clomiphene citrate or you're giving somebody letrozole, then it's ideal to check progesterone, because we need to know if we have given somebody letrozole and we've given somebody clomiphene citrate, have they ovulated? Have they responded to it or not? How would I know that I've given letrozole to this girl and she's gone away and taken the letrozole? What has she done? If they've ovulated the first time, then you would assume that the second and the third time they will ovulate as well. But at least once, you should always do a progesterone level in the luteal phase to see how they have responded. Sometimes with clomiphene, we give one tablet only. We start with one tablet, and one tablet is not enough. If somebody's BMI is 35, to be honest with you, I would not start ovulation induction unless I bring them down in BMI a little bit, because then it improves their chances. As obesity, we all know that it's a risk factor for miscarriage as well. So what I try to do lifestyle first, and then I will put them on ovulation induction and metformin if their insulin is high. If their insulin is normal, I never add metformin. But for example, I've tried letrozole twice and it hasn't worked and the HbA1c is high, then I would add metformin. And then the first time I definitely do a progesterone. If they're not pregnant, second time, we do bulk billing cycle trackings here. So with cycle tracking, what happens? If a woman comes in on a day 10, they would do a cycle tracking, and then they would do an ultrasound to see, they can see the lining is building, the follicle is there. I tell them, look, you've done one cycle of cycle tracking. Just do that. You know, when did you ovulate with this treatment? So next time, you just follow this exactly. And they're very reassured that, oh, yes, I ovulated on day 14. I don't ovulate on day 12. I've ovulated on day 14. My lining was really good. So they narrow down their fertile period as well, from rather than day 10 to day 20, probably from 12 to 16, because they've actually seen it. So then the next 2 cycles are better for them. Then you don't need to do it every single time. Once is okay.
Okay, patient with normal BMI, but oligomenorrhea due to PCOS, not responding to COCP and not having periods. What are her treatment options?
Oh, that has to be investigated. I think that patient has to see somebody. If they have got oligomenorrhea and they're not responding, because if you're putting somebody on the pill, then PCOS have positive or negative is regardless, because the pill is supposed to make their lining and shed the lining. So if the pill, if she's not responding, she might have Eschermann's. It has to be investigated.
Okay, we'll let you go on to the next case, Rabia.
Mm-hmm. Okay, so case 3. So this is a 29-year-old G0P0, primary infertility for 3 years. AMH is 12. She's got known grade 3 endometriosis, which was treated with laparoscopy. So she's actually a nurse, very, very nice girl. She was sent to me from a gynecologist who has done a laparoscopy for her and have cleared her endometriosis, but told her that it's hard for you to fall pregnant, so you go and see an IVF specialist. So she came to me. We started IVF in the public unit, and she made beautiful blastocysts, and we transferred all of them, and she didn't get pregnant. So I decided to, after this one cycle, we decided to have a laparoscopy again to exclude if she has got a high-risk helpings. Because if somebody has got treated treated endometriosis with laparoscopy and made good quality blastocysts, 3 transfers, I thought I'll go and take her. And this is what I found when I went there, to my surprise. This is her, sorry, they're not very clear. So I'm going to tell you, so this is her right tube and ovary. It was a tubule ovarian abscess on the right side, completely covered and peritonealized in adhesions. So you can see this, and you can see the scar tissue here. So sorry, it looks a bit gross. So this is all what, and this is all full of pus. So I actually did a self-injectomy for her on the right side and separated her ovary. You can see this tube, it's all endometriosis. And took her right tube out and put a clip on the left tube because they were both high-risk helpinges. And then after that, she became pregnant. And I delivered her little boy, and now she has just had a transfer last Saturday, second baby. So this is case 4, 32-year-old G2P0, 12 months of primary infertility, menstrual history is fine, irregular menstrual cycles, normal menstrual flow, mild dysmenorrhea, hyperprolactinemia. She was on bromocriptine. BMI is also high, is 35. So investigations, we did ultrasound, PCOS, TSH, prolactin was normal, partner's sperm was normal, impression was anovulation secondary to PCOS. So plan was ovulation induction, no pregnancy after 2 ovulatory cycles using letrozole. So then we sent her for a dye study, patent tubes, and there was a septum. And then I resected her septum, and then she became pregnant. So this was on PCO. After resection of the septum, she actually had simple endometrial hyperplasia and put a Mirena in the rooms for her, because after the histopath came back as hyperplasia, we put Mirena for 3 months and then did a Pipel biopsy in the office. And then started her on letrozole again, and she became pregnant. So she, again, I delivered her son as well. She has gestational diabetes during pregnancy. I delivered her son, and I offered her to start another cycle to finish her family, but she does not want to have any more children, and she does not want to have her uterus removed as well. She's 40, so I've put a Mirena in again to stop her from developing hyperplasia again.
A patient treated with hyperprolactinemia.
Yes.
Oh my God, these words are testing me. What are the chances to fall pregnant naturally, and are there any associated complications can be in this patient which we need to look for?
Okay, so if somebody has got treated hyperprolactinemia, first of all, we need to know why they have got hyperprolactinemia. Does this patient have got a microadenoma? How is this microadenoma treated? Is it treated with cabergoline or is treated with Dostonex? How it has been treated? If it's, and is the prolactin levels being monitored? If the rule of prolactin is that if it is high once, we always repeat it again. And we make sure that we repeat it in the follicular phase of the cycle. So day 2, day 3 type thing. If you have got a patient whose prolactin is 500, 600, but they're having regular periods, there's no need to treat it. If they have been treated of the prolactinemia and their prolactin levels are now normal, and they're having regular periods, they have got a very good chance of falling pregnant naturally. No problems at all. If the trick is if they're ovulating, they should fall pregnant unless they have got something else. So if somebody has got ovulatory cycles and prolactin is normal, mind it, if the prolactin has been high before, it can go high during the cycles without knowing, because we don't check them all the time. So it is possible. We see that during IVF cycles as well, that if somebody has got hyperprolactin and we give them Dostonex, we do a cycle during the cycle, as soon as the estrogen goes up, the prolactin goes up as well. And sometimes it happens that they don't respond to FSH injections. And then we said, oh, this woman took the Dostonex 3 weeks ago. Check the prolactin during the cycle. You check the prolactin, it's now 1500. So you give them Dostonex and estrogen will start rising. So either you put them on a maintenance therapy, which is like 2 weeks, you give them half a tablet 2 weeks, or whichever endocrinologist is treating her, or a fertility specialist is treating her. So if they are regularly nice levels, then pregnancy shouldn't be a problem. And you don't need to worry too much in pregnancy, because in pregnancy, prolactin levels are high anyway. We don't need to treat them during pregnancy. And pregnancy is not a contraindication if they're on Dostonex. Yeah.
Has been trying to get pregnant for a few years. She got pregnant, and at 5 weeks of pregnancy got spotting, and she had a miscarriage. What is the chance of trying progesterone for spotting with the first pregnancy?
Okay. So first of all, if somebody is trying for pregnancy for a few years, we need to know why she took few years. Is there a sperm problem? Is there an egg problem? Is there an age problem? Or there is endometriosis, or there is something else in the pelvis. So if there is an issue that she hasn't been able to fall pregnant and finally fell pregnant and had a miscarriage, most likely this woman has got something going on with her. So we need to investigate what is her egg count, a good ultrasound, a good high-COSY ultrasound to see if the tubes are fine. Is there anything in the uterus? If this woman has got PCOS, then yes, she has got a role of progesterone in early pregnancy if you have a spotting. But if somebody has got good HCG levels, then yes, progesterone would work. But if it's a biochemical pregnancy, like this one looks like it might be a biochemical pregnancy that the HCG was like 270 and very early they lost it, then we need to investigate. And if somebody's been trying for a long time, how long will we allow her to try more? That's the other question.
In IVF patients, the use of vaginal progesterone, when to commence and till how many weeks?
Very good question. Whoever has asked this question, I love that, GP, because so many patients are confused about this. Look, if we talk about evidence, in IVF pregnancies, historically, we only give progesterone for up to 2 weeks. And in all over the world, progesterone is given in a different forms. Like in Australia, we only give it vaginally. In India, in England, in Spain, they sometimes give IM injections as well. And some places they give PR progesterone. So all the routes are similar. Vaginal, they say that there's got a higher concentration in the uterus, so vaginal is better. Now depends if somebody has got PCOS, somebody has got endometriosis, I like to use it up to 7 weeks scan. And if 7 week scan is normal, then I would tell them to just wean themselves off. If somebody has got repeated miscarriages previously, or have got very bad PCOS, I continue sometimes up to 12 weeks. So it is different. Ideally, most fertility specialists are coming to a consensus that, look, let's give it up to 7 weeks. But not all the patients can afford to take. It is an expensive drug. And some girls have got really bad bloating. Some girls have got vaginal itching and things. So in IVF pregnancies, ideally we give it up to 2 weeks. Then if this is a normal, otherwise normal, perfectly fine, normal BMI, normal AMH, no other major issues, unexplained infertility, 2 weeks is more than enough. You don't need to give it more, because once the pregnancy picks up, you have got your own corpus luteum as well. You have got your uterus that starts making progesterone. Placental tissue will start making progesterone. So you don't need to give it for a long time. But if they need to continue longer than 2 weeks, then they should speak to their fertility specialist. I like to continue up to 7 weeks.
We hope you
all
have
my
enjoyed
girls
this
until I
GP
know that
education session.
pregnancy has
If you wish to
settled,
gain
there's a
CPD points,
heartbeat,
this
and then I'll wean
activity
them
is
off.
now a quick lock activity, which means you need to head to the Royal Australian College of General Practitioners website to log your own points. We hope you can join us for more of our GP education in the coming weeks. Thank you.